Hello. Oh, sorry, very loud. Thank you very much for having me here today. I'm very excited to have spent the last 2 days learning that there's the same problems that we face over the water that there are here, is that there's multiple systems that we use within healthcare. None of those systems speak the same language, and we don't have permission or access to be able to access that data to be able to pull meaning. Another thing that I think which is being done but not readily talked about is that the amount of overcreation of content we have. Everybody is filling their solution with more content, which puts a real pressure on the clinicians to be able to generate novel content on a replicable place. So my background is a physiotherapist, but now also digital transformation specialist, and the area that I work in is orthopedics. And if you kind of have a look at this graph, this table here, trauma and orthopedics is one of the biggest demands of outpatient services in the UK. So over 111 million people have outpatient appointments, of which trauma and orthopedics is the highest specialty. And this is going up and up every year. But equally, the number of patients who don't attend those appointments is actually going up also, which is showing that we're not really serving those patients' needs in the upcoming future. So the NHS produced this brilliant document, which I have used as evidence to do everything I've done for the past couple of years. And it really clearly stated that unless we reshape care delivery, harness technology, and drive down variations, then patients who would have been cured will actually be harmed and outcomes will not persist. So why orthopedics? It's my speciality. And yes, we are all different, our genomes are different, but actually how we heal from simple fractures is a scientific process. It's a biological process that takes part in steps and processes, and we have small variations if we smoke or have our diabetes, but actually we are all the same in the way that we heal from these. So why are we treated in so many different ways, depending on where we live or what day of the week it is? We actually want to have preloaded dice to be able to receive our treatment. So in Brighton, back in 2013, myself and an orthopedic consultant looked at how we manage patients in the orthopedic department. And we asked the question, is the current model the most patient-focused, cost-effective, and evidence-based model that we could be using in the UK, or actually nationally? So I'm going to give you a snap picture of what it used to look like, and you can see if you think that this is very patient-centered. So yesterday, it's pretty snowy here. One of you guys accidentally fell and broke a bone in your foot. You had to go to the emergency department. And if you were actually in the UK, you'd be told, yes, you've got a broken bone, we'll put you in a plaster, and you can come back to see the orthopedic specialist tomorrow if you're lucky, or if it's the holidays, maybe 10 days, just depending on the demand that there was. You'd queue all the way around the hospital car park. We actually made it into the local car park, the local newspapers, but our car park wait was 90 minutes just to get to the car park. You then arrive at the hospital and find that the car park is nowhere near the clinic that you actually have to go. So you're in plaster, on crutches, in pain, and you have to hop 80 stairs or navigate 3 separate lift shafts to get to your appointment. You then get to the appointment and you see a waiting room much like this here, like the auditorium. Lots of people sitting around, and maybe another sign on the wall that says, clinic overrun, 2-hour delay. So you're in pain, you've hopped there, you've struggled to park your car, you think this appointment must be really, really valuable. I definitely have to be here. And you go into your appointment and get maybe 5 minutes, if you're lucky, to be told, yes, you've broken that bone. You've already been given the treatment in A&E. We'll see you again in 6 weeks. Where was the value in that? But actually, before we changed any practice, we asked patients, did they think this was an effective way of managing their injury? And 45% of all patients had taken time off work to come to that appointment. And the question I didn't ask, and I wish we had of, is did somebody else take time off work to bring you to that appointment? Because actually you've broken your foot and you probably can't drive. And 44% of all the patients were discharged after that first appointment, which asked the clinical question, do they really need to be there? And only 44% of our patients had any idea with regards to what to do next from a rehab prescription. So the doctors were great at giving them diagnosis, but absolutely no information to empower them to recover themselves. Although satisfaction was pretty good, 76% given that service. But why do we need to change? The NHS, like many health economies, has absolutely no money. I heard an interesting statement the other week in the newspapers is that the NHS is using yesterday's technology tomorrow and using tomorrow's budget yesterday, which is probably quite replicated across the national. We want to reduce sick deficit. We want to be able to empower people to be back at work. We want the specialists to be doing what they're trained to do, okay? We have spinal surgeons who've trained years to be able to do spinal surgery, and they sit in a clinic seeing toe fractures. It's just mind-boggling in the sense of actually, why are we doing it that way? And a patient can get completely inconsistent treatment within the home hospital. And also nationally, I've seen one simple toe fracture be managed by doing nothing, which is quite appropriate, to being in a plaster for 6 weeks, which has a massive impact. So why is there such inconsistency in care within the same locations and then nationally? So we set about by just thinking, let's change this in 4 simple ways. We wanted to put the patient at the centre of the model, okay? So let's bring first-line patient experience to them within the comfort of their own home. You're the one that's broken your bone. Why are we dragging you into hospital to see us? We wanted all decisions to be made by the top-level consultant. So no matter what your injury, no matter what day of the week it is, it's the right orthopaedic specialist that sees your case. We wanted to make sure that all patients receive standardised, high-quality care, which is evidence-based, and we wanted to reduce the number of knock-on appointments for outpatient services and for imaging, such the like. So with absolutely zero investments, we did what we kind of call our first phase delivery, and radically changed the way we managed outpatient services. And in the NHS, this is pretty radical, because overnight we just cancelled outpatient clinics and said, we're going to introduce a virtual model, with the idea that we were meant to work smarter, but not harder. But I definitely worked harder for the first 9 months while setting up this model, but now it's running really smoothly. So you've still unfortunately broken your foot. You had to go to A&E. We can't really stop that part at this moment. But instead of you coming to hospital, you're at home, sitting, resting your foot with a cup of tea, while the doctor looks at your images and says, yep, okay, it's a simple fracture. We know how to treat that. We can send you some online pathways to recover from that injury. So then the physio will call the patient at home to check that there's nothing that was missed in A&E, and also to advise them on the information with regards to their management. And all of this process takes the doctor about 1 minute per patient to be able to do this process. So it's much quicker. And initially, when we had no money, I used YouTube videos to be able to get the patient information out there. I used SurveyMonkey to be able to get the outcome data, and different sort of free modalities, because that's all I had to do to the start one. So now let's compare the satisfaction. So I've spent no money, and patients are now at home. So 45% of patients taking time off before, we've reduced that now to 16. We've increased our discharge rate to 57%, and now 85% of patients have a good understanding of how to do their rehab, and our satisfaction was higher than a face-to-face appointment. So by spending no investment and actually seeing patients at home, we've across the board managed to improve patient objectives. And so financially, let's look at this side of the model. So in the UK, I don't know how it works in the Finnish healthcare system, but if somebody goes to an outpatient appointment, the NHS pays £151 for you to go there. So if you've broken your toe, it costs £151 for you to go to that appointment. A follow-up appointment is about £59, but a virtual appointment doesn't need to be the same price as a face-to-face appointment. We can actually cost that a lot lower and still be able to deliver an effective service. So a virtual appointment is less than half the price of a face-to-face. And the fact that we're discharging more patients meant that in Brighton, in one clinic, in 3 years, we had over £1 million in savings to our commissioners for this type of service. But I really like to use the iceberg picture on this, because that's £1 million savings in just the cost of a face-to-face appointment. But what we can't categorise, or if I had an economist who wanted to do some work with me, is actually how much we're saving with there being no nurses there, no notes are being tracked around the hospital, no transport services, bringing patients into the hospital. The consultants who would have been seeing that toe fracture are now in theatres doing the operations that they need to be. So actually the cost savings here are huge. So back in 2015, I sort of thought, okay, we're doing this in one hospital and I think it's going brilliantly. How do I actually share this across the UK? So I thought I want to be able to share practice. And actually, the only really good way of doing that was applying for a couple of awards, okay? And this was my little sneaky cheek in there, is I applied for 3 awards and managed to win all of them in 1 year. And that got me leverage with companies like 3M and Microsoft and a write-up in The Guardian, which is our national newspaper, to actually say, well, actually, this is a really good silo of care that we're doing in Brighton. How do we bring this onto a national or an international level? So at the beginning of 2017, when I was still working in Brighton, we launched a platform based on Microsoft Dynamics. And Microsoft Dynamics, I don't know if anyone's very familiar, is basically a CRM or a client relationship management system. And ever since I've known about this type of solution, I thought, if we stop thinking of patients as patients and actually thinking of them as customers, they may get better customer service in the healthcare system. These systems are designed to offer customer service, but we don't really have anything like that in the healthcare. So at the beginning of January last year, we deployed Microsoft Dynamics so that patients would be able to get access to all this information. So if you were referred with that foot fracture, you were then given a unique login to be able to see the YouTube videos that are designed. But then I thought, the YouTube videos, I did them 4 years ago. Research moves on. How do I actually keep up to date with this? I don't want to have to be recreating content constantly. So this year, I joined up with a company called Healthcare Business Solutions to create Virtual Lucy. So Alexis has, Amazon has Alexis, and we have Cortana, so why not Lucy as your health bot? So this is a way of managing your solution online so that multiple hospitals can benefit from having the same content across all of the different sites. So basically, Lucy is an end-to-end solution for virtual fracture clinic management or other kind of injuries. We can receive secure referrals. It can be integrated into an existing hospital system to be able to receive those automatically. It provides a triage tool so that patients can be easily triaged very quickly. And then it has a rehab app for patients and a secure telehealth portal and a chat function and all those sorts of things. So this is just an example of what the app would look like. It's currently in the development, but the app is called Lucy, but it has the ability for every hospital to actually internally brand the information. So although it's central information which has been designed by experts and clinical leaders in that field and is peer-reviewed, and every year it's reviewed, it looks like it's actually coming from that hospital, which is something that they quite like. The written information, we have it in written format, but also in video format. And again, this is the same. So if you sprain your ankle in Brighton, you can get the same information as if you sprained your ankle in London. And actually getting the same consistency of care is really, really important. It also has in video format, so all of the exercises there are demonstrated. And often when I'm a physiotherapist showing you an exercise one-to-one, how much of that exercise do you actually take in? And I'm always amazed when people come back and say, yes, I've been doing my exercise like this. And you're like, that's not what I taught you. So actually being able to have a video format to be able to look at that exercise. I'm just going to see if that video works. No? Can you play the video for me?
Start in a seated position with your legs straight. Invert your ankle by turning the sole of your foot towards the midline of the body. Do not move your knee or the hip to create this range of motion. Move your ankle only.
And that example for that exercise is something that's done very badly, but that person seems to do it very clearly, and you'd understand what you're doing. There's also a pain scale on the bottom, so that if you're doing an exercise and you click 10 out of 10 pain, that'll send an alert to my dashboard as the clinician to see that one of my patients is struggling. And actually, in the clever bit in the future, once we have lots of people being treated for the same injuries, and we know actually at week 1, they're all getting 10 out of 10 for this exercise, do we actually need to change that exercise and bring it in later into their program so that we can actually adapt how we're treating patients as we go along? It's also got an integrated telehealth function that you can play the exercise at the same time. So if somebody is struggling with their exercises, me as their physio can have a face-to-face with them while playing the exercise at the same time to check on technique and things like that. So as a physiotherapist, I get a bit excited about statistics, and especially statistics that are done for me. That's even better. Because in 2015, when I tried to review our service, I took out 2 weeks from work to crunch all of this data in these Excel spreadsheets. I'm hopeless at pivot tables, so it really wasn't very effective. But whereas using the CRM that Microsoft have here, it's all done automatically. These tables are drawn in automatically. I know how many patients have been referred with a broken shoulder. I know how many needed follow-up. I know how many completed their outcome scores. I know how many A&E got the right diagnosis for. And I don't have to spend hours of my clinical time looking into that data. It's all just on a tab for me, which is very exciting. So, mail merge. Mail merge is something that has been in existence for however long, okay? But in the UK, I don't know if it's the same in Finland, maybe someone can help me here. If you go and see a specialist, they have to dictate a letter, okay? That letter in the UK then goes to India to be typed up. It then comes back to the UK for a medical secretary to check it for validity, and then it goes to your general doctor. And that process takes 2 weeks. But if we already have your clinical information in a computer system, why can't that letter be generated automatically and we just add in any pertinent text that's important for you? Just that simple thing is not being used in the NHS, and it astounds me that it isn't. So mail merge, yeah, a technology from however long ago, still not even being used. The other features that really excite me, and the real reason that I wanted to get into this project on a larger scale, is that we will all act in little silos of hospitals. There's 250 hospitals across the UK, and nobody knows what each other's are doing, who's performing better. Everyone thinks that they've got the right answer. But actually, by having one platform with 120 evidence-based rehab protocols for every injury, we can compare hospitals. And actually, there's a benchmarking function. So you can see, are you doing better or worse than another hospital for treatment of that same injury? There's certain injuries that we don't agree on the treatment. We can actually learn from the hospitals that are doing better with their outcomes. Other things like automated letters to clinicians. So in the UK, we have to kind of prove our services are beneficial and they're actually better for patients. And I don't want to have to spend hours generating a report. So I just want to press a button and then a snazzy one-page spreadsheet, a one-page PDF gets printed off, which tells me all my outcomes. That's the sort of thing as a clinician that's really, really valuable to me. So one of my kind of key messages when thinking about sort of virtual transformation is we're just really using digital technology to move away from costly one-to-one appointments and working on a one-to-many process, but actually for a lesser cost. Because once we've designed it, it can happen in the background, in the processes. And with the advancements of AI and bots, that's going to get even better. Because me as a clinician, I don't want to be treating toe fractures, okay? They get better. I want to be seeing patients who really need my clinical expertise. And I see the digital technology advancements as the way of being able to achieve that. So not taking away from the clinician, but empowering the patients who really need to be with me to get those appointments straight away. So Virtual Lucy is in design and process, and we're sort of starting off with orthopedics as the background. But this same principle can be applied across medical healthcare. And I've already heard many people today say we've got too many apps, too many different ways of doing it. So actually what I'm trying to do is think, okay, what platform can service the whole pathway? Can look at from referral to rehab, from outcome measures to statistics. And actually the platform that we've designed in this sense really truly believe that it can do that. So our roadmap is looking at covering the whole of outpatient services across the UK and then also internationally. Thank you.